Hello everyone, my name is Jen Nolan and I'd like to welcome you to the first webinar in Move Muscle, Bone and Joint Health 2018 Musculoskeletal Health webinar series. Tonight's webinar is on the topic of managing community expectations in stem cell therapies for musculoskeletal health. I'd like to thank Stem Cells Australia and the Australasian College of Sport and Exercise Physicians for funding the webinar so it can be offered free to all participants. Move Muscle, Bone and Joint Health has some great webinars in this first half of the year, and the list should be on your screens now. You can purchase the webinars individually or as a series, and the recordings of previous webinars are available for purchase at any time. Our first presenter for this evening will be Dr. Mark Young. Mark qualified in London before becoming a general practitioner in Alice Springs. He joined the Australasian College of Sport and Exercise Physicians Specialist Training Program in 1996 and spent the next 4 years at the AIS in Canberra prior to the Sydney Olympics. Mark now works in a private sports medicine clinic in Brisbane and in stem cell research. He is currently a visiting research fellow at the Translational Research Institute at the Queensland University of Technology and a Commonwealth Government-appointed member of ASADA's Medical Advisory Committee. Our second presenter for this evening will be Associate Professor Megan Munsey. Megan is based at the University of Melbourne, where she heads the Education, Ethics and Law and Community Awareness Unit at the Australian Government-funded Stem Cells Australia initiative, and she is the Deputy Director of the newly established Centre for Stem Cell Systems. Megan is a member of the International Society for Stem Cell Research Ethics Committees and on advisory groups to such organisations as AusBiotech and the International Society for Cellular Therapy. Without further ado, I'll hand proceedings over to Mark, who will present first. Thanks very much, Mark.
Thank you. Thanks, Jen. We'll just go through to my first slide if we can. Thank you. I think I'm talking on the science and ethics of mesenchymal stem cells. The most important thing I think on this first slide is to say that I have no conflict of interests. I want to start off talking a bit about medical ethics. The doctor-patient relationship is the basis of all our medical ethics, and the Hippocratic principles of medicine include beneficence, maleficence, autonomy and justice. We remember those as do no harm, work for the benefit of the patient and respect individual rights, and justice for the wider community benefit. Now we as doctors have some privileges, and I acknowledge that, and that is it is always assumed that physicians act in the patient's best interest, and doctors possess the clinical freedom to prescribe unproven and novel therapies, including innovative therapies. The medical profession and the legal profession traditionally are the two professions that can self-regulate. But what's happening in this ever-changing world is that there is technologies being introduced at a very rapid pace where maybe our current medical ethical framework is not able to keep up with the introduction of those technologies. I want to talk about the difference between medical research and medical innovation. Medical research is population orientated and typically undergoes independent ethical review. That ethical review is by an HREC, a Human Research Ethics Committee, and most of them in Australia should be approved by the HMRC. The prime focus of this HREC is to make sure that the safety and welfare of trial participants is paramount, and they can stop a clinical trial, whenever they want. So medical research for a new product typically follows the clinical trial pathway of phase 1 is safety, phase 2 and 3 are efficacy, and phase 4 is treatment surveillance. And this is the same for biotechnology products as it is for pharmaceuticals. All potential conflicts of interest should be disclosed, and trial registration is encouraged. And usually we're lucky in that we're insured through the institution for this, and there should be no cost to patients. And this is the clinical pathway for many, many drugs that are being used in Australia now. Now there's a difference in medical innovation. This is orientated at an individual patient, and we as doctors have the privilege to use medical innovation. It allows us to undertake a therapy without it going through a clinical trial. So we can prescribe innovative therapies to individual patients, such as using a medication differently to how it's listed on the PBS, or even the manufacturer's guidelines. An off-label prescription, for example, many drugs used in pregnancy have never been tested in pregnant women because it would be regarded as unethical, but we all know we can give penicillin to pregnant ladies because it's been done off-label for many years. And that's as a result of medical innovation now becoming accepted treatment. A different surgical approach is probably an even more important way that medical innovation has changed the medical society we live in. So medical innovation is extremely important, even though it's poorly regulated. It's probably the most important driver of clinical progress. As I say, it can be used for new surgical procedures. It can be used before a treatment becomes an accepted therapy. And as good clinicians, we're always adapting the way we treat. However, if an innovation differs significantly from current accepted practice, it should be considered experimental or novel, and a research approach should always be undertaken if appropriately. So how are we regulated on innovative therapies? Well, when a new therapy comes along, it's usually the TGA, the Therapeutic Goods Administration, and Megan's going to be talking a bit more about the TGA. That determines what is permitted to be used as a clinical therapy. And then we as clinicians can decide whether we would like to use that innovative therapy if we think it's going to help our individual patients. And we have responsibilities, and AHPRA, the Australian Health Practitioners Regulation Authority, coordinates health practitioner boards for many allied health providers as well as medical practitioners. Then there are the professional bodies, the AMA, AMC, and specialist colleges. I think if doctors do make claims outside of expected advertising, making unrealistic expectations, doctors, like anyone else, are able to be challenged by the ACCC. Medicare has no role in innovative therapies, so when someone's using an innovative therapy, it's not accepted, and we can't use Medicare, which does police medical practitioners. The significance of that is that we have no information from Medicare data how much innovative therapy is really being done in Australia. And these bodies are reactive. They typically initiate investigations on complaints, e.g. from patients or organisations. Now we're talking tonight about stem cells, and it's a good example of an innovative therapy. Now, just going through the background and science of stem cells, all stem cells have two properties. One is they can proliferate, they can reproduce, they can make more of themselves, and the other is that they can differentiate. A stem cell is a primitive cell that can differentiate into a mature adult cell, and it can differentiate into lots of different mature adult cells. And they're classified by their source, i.e. are they from the bone marrow, their potency, how many tissues they can differentiate into, whether they're from the patient, that's autologous, or whether they're transplanted, that's allogeneic. So you can take a bone marrow allogeneic stem cell from one person and give it to another. Mesenchymal stem cell is only one type of stem cell, but they are the mesenchymal tissue repair cells. And they are really the cells that are promoting the topic of regenerative medicine. Mesenchymal stem cells are strongly anti-inflammatory. They're found in, so the significance of that is that they're not rejected. So they're like the O negative blood, it's not rejected. It can be used allogeneically. They're found in every single tissue. Every living tissue has mesenchymal stem cells in. But contrary to what many people tell you, they're an extremely rare cell. They were only discovered in the 1960s, and they typically need harvesting and expansion. That's expensive, time-consuming, and highly regulated. So if you take a bit of tissue and you extract the mesenchymal stem cells and you expand them, that means you proliferate them, that's going to take weeks, and it has to be done in a highly regulated and sterile manner. Now here's a diagram showing a mesenchymal stem cell which can either self-renew or differentiate. Now mesenchymal stem cells can form bone, cartilage, muscle, bone marrow, tendon or fat. So who is the typical stem cell patient? And many of us are clinicians and allied health clinicians on this audience. They're typically a young adult sports person or even an older active individual. They suffer from painful degenerative musculoskeletal disease affecting their quality of life or ability to play sport. Typically they're keen to avoid joint replacement surgery. Having a knee replacement for painful, relatively mild osteoarthritis in your 40s is not a very palatable idea. All these patients are typically very wealthy, they're well educated and proactive, and they're prepared to take a risk to improve their quality of life. So what is the evidence that mesenchymal stem cells will work at regenerating joint cartilage and tendons? Well, most of the research is done with expanded mesenchymal stem cells. So they're the ones done by the research community. They are the ones that take weeks to prepare, and they're purified and the numbers of stem cells are known. So you might be injecting 100 million stem cells in a research trial into a knee, an osteoarthritic knee, to see if it's going to regenerate cartilage. Now phase 1 trials are the safety trials, so you go through this process. Now almost certainly mesenchymal stem cells, and I'm not talking about embryonic stem cells or any other stem cells, or mesenchymal stem cells are probably safe in mesenchymal and musculoskeletal conditions. Sure, there's a risk of infection and bleeding, and those are clinician dependent, and theoretically there's a risk that they will grow into an inappropriate tissue. So you can theoretically inject bone marrow mesenchymal stem cells into a degenerate tendon, and theoretically it can form bone rather than tendon, but fortunately that seems to be extremely rare and essentially it doesn't occur. Mesenchymal stem cells get their cues from the local tissue. They receive signals from cytokines. So you can put an undifferentiated mesenchymal stem cell into a tissue in an animal, and that mesenchymal stem cell will differentiate into the tendon or into cartilage or into bone or fat or muscle. It sounds this wonderful cell. Phase 2 and 3 trials are the efficacy trials. So once something's been proven to be safe, we want to know if it can work. But as yet, there's no high quality evidence of efficacy in terms of cartilage regeneration in osteoarthritic joints or even tendon regeneration in tendinopathy. There is some good evidence for pain relief in some of the clinical trials that have been published. Preferably, the best way to establish efficacy is to do a controlled clinical trial where you have a placebo group that don't receive the treatment. Phase 4 is post-market surveillance. So you can't really have phase 4 unless you've had phase 1, 2 and 3. Now, clinical evidence is not just derived from research, as I said at the start, it also comes from results of innovative therapy. And when you're looking at the clinical evidence, i.e. what we should be recommending to patients, whether we're a medical clinician or even an allied health clinician, I think we should always try, if possible, to use high level of medical evidence. The highest level of medical evidence is a systematic review with meta-analysis. That can only be arrived at when you have a number of systemic, when you have a number of placebo-controlled trials, preferably double-blinded. So in mesenchymal stem cells used as an innovative therapy, there are undoubtedly multiple self-reported case series measuring pain and lifestyle. They're usually non-expanded mesenchymal stem cells. Cool, Mike.
Which can be compared with other objects or events. Would you like to hear more?
So low-level evidence is quite. There's a lot of published trials. Sorry, my Siri is talking, and even though I've got my phone turned off, I'm just going to turn it off. Then there's high-level evidence, which is level 2 evidence or above, and that's a double-blind placebo-controlled trial. And it should ideally measure regeneration, not pain. This should be independent of financial influence and bias, and I admit doing a high-level double-blind placebo-controlled trial in private practice is very difficult. Currently, there's little or no statistically significant evidence to support tissue regeneration of expanded mesenchymal stem cells in degenerate joints and tendons. Therefore, current evidence cannot support, and I've tried to look at this objectively, the support of non-expanded mesenchymal stem cells. And it's the non-expanded mesenchymal stem cells that Megan will be talking about a bit later on, but they're the ones that are being promoted heavily in Australia by some medical practitioners. For example, I mentioned earlier that in a clinical trial you might give 100 million mesenchymal stem cells, you might inject that into a joint. In a non-expanded mesenchymal stem cell, like an autologous MSC as such, they're probably giving 5 million MSCs into this joint and claiming that there's many more cells being used. But the number of stem cells, if you do not expand that your solution, is very, very low. Now, there's one study that is a level 2 trial that is a randomized, double-blinded safety and efficacy trial in osteoarthritis of the knee. This was done in Sydney by a company called Revolutionise. They had 20 participants in each group, so they had 40 patients. 20 patients had a saline injection into their knee, and 20 patients had a non-expanded mesenchymal stem cell solution injected into their knee. On average, there were 6 million mesenchymal stem cells, as far as I can see, given into each patient of those 20 patients. All patients had a liposuction to start with, and the ones that were given placebo were later told they had placebo, and they were offered the stem cell group later. They had a 12-month follow-up, and pain scores, MRI changes, and cytokine levels were measured. This was called the OSCARS trial, and it is still unpublished. What this showed was that there was no difference in cartilage regeneration in the active group receiving stem cells compared to the placebo group. There was no difference in pain scores over 12 months in the active group compared to the placebo group. There was possibly some cytokine, which is a growth factor difference in the blood, which may have been statistically significant. But what patients want, they want pain relief and they want cartilage regeneration. They're trying to put off having their total joint replacements, in this case total knee replacements. On the left is the actual results of this trial, which is no longer available on the internet, but fortunately I have a copy of it. And it shows that the placebo and treatment group is identical. That is level 2 evidence. On the right of the screen is a very similar graph, only showing the active treatment group. In fact, it's an identical graph. This is the graph that, unfortunately, one of my colleagues presented at a conference saying how good mesenchymal stem cells were. This graph failed to mention that the placebo group also had a near 50% reduction in pain over 12 months. This is level 4 evidence was presented at a scientific conference knowing that there is level 2 evidence from the same trial. And this is the evidence that sometimes patients are given when they go to their doctor and ask for evidence of the effectiveness of this treatment. So are mesenchymal stem cells a placebo? And I'm talking about autologous mesenchymal stem cells being used in Australia as same-day treatment by medical practitioners. Well, if you look at what are the factors involved in placebo, patient factors are very important. The motivated patient's more likely to receive a placebo effect. Patients seeking alternative therapies and patients in chronic pain are going to receive more of a placebo effect because their scoring of their pain is not the same as someone's scoring of the thickness of their cartilage. Pain is a subjective measure, whereas cartilage thickness is an objective measure. So subjective measures are very prone to placebo effect. And there's interventional factors such as the cost. If you go to a patient and give them a cheap placebo or you give them an expensive placebo and say to them, you're getting an expensive tablet or you're getting a cheap tablet, guess what? The patients receiving the expensive tablet report better improvement in their pain, even though both may be placebo. When you give local therapy over generalized administration, if you give an injection into a joint rather than a tablet into the mouth, and they're both placebo, the patient receiving the joint injection reports improvement. When there's a ritualistic preparation and having a liposuction bone marrow aspiration, people in white coats running all around you and 2 hours later being given it back into your knee, that's a very ritualistic preparation. The patient is awake through all of this. And when it's a cutting-edge treatment with lots of hype, these are all independent factors and would explain why in the previous trial so many patients improved with placebo. So we have to be aware of the placebo effect in medicine, and I think there are many reasons why saline is just as effective in the one and only level 2 trial that is published, that hasn't been published. It was done by a financial company, a biotech company, and maybe there are reasons why it's never been published. Thank you. I'm going to leave it to Megan now.
I think I'm still off air. Can someone, oh, hi. So I think I'm on air now. So thanks, Mark. That was a fantastic introduction to the facts on where we're at in the field. And what we really want to do now is talk about some of the hype and the hope that Mark has alluded to. So what I want to start with is some of these sensational headlines that appear in the media coverage, in the media, and that undoubtedly capture perhaps your attention, but also the attention of patients. The patients that Mark has already described to you, perhaps young individuals who want to retain their active lifestyle, or those with, or active older patients who are suffering from pain but want to retain as much of the quality of life as they can. So headlines like these and the stories that accompany them often present stem cells, and particularly these MSCs, as almost like a silver bullet, that these stem cell treatments are revolutionary, that they are able to bring these athletes back. And in fact, this next headline, I thought, captures it beautifully, that stem cell therapy is no longer just for high-paid athletes. It's available for you. But what I want to talk about now is at what cost. So having captured someone's attention, someone who perhaps has a sore joint or problems with their bone or muscle, people will hop online. We all know about Dr. Google, and quickly searching for stem cells for knee repair, you'll come across a lot of information, but also paid ads, and you can see the little ad symbol here. Here's some of the clinics that I found, and I actually am involved in a large research project where we monitor the advertising and the promotion of these clinics. And some of the ads here, as you can see, is it's presented as an alternative to joint replacement with over 600 patients treated at a 90% success rate. What is the evidence that backs up that form of advertising? The next ad is promoted as the one and only insured stem cell product, guaranteed for your safety. It's got a 99.9% success rate with a free consultation. Who wouldn't want that? So if you were to click on this Australian clinic, you'll find a website page like this. It actually has patient testimonials on it. And if I just zoom in here, this testimonial is apparently from a woman called Juliana, who's 66 years old, and she's been living in constant pain. She lacks energy and feels depressed. Less than 4 weeks after treatment, the pain's gone and she has energy of a 40-year-old. This is pretty compelling evidence, particularly when she goes on to talk about the fact that her grandchildren, she's able to now play with her grandchildren. She wouldn't hesitate to recommend this. For many people, this will appear very convincing. And obviously, it's of great concern to us that information like this is promoted unchallenged. The reality is that selling stem cells is big business. It's big business around the globe. You might remember about 10 years ago, there was a lot of conversation around stem cell tourism, where Australians and indeed patients from many other countries were travelling all over the world, particularly to countries with perhaps low regulation or a lack of regulation, such as Mexico, the Bahamas, parts of India and China. And they were seeking out stem cell treatments or alleged stem cell treatments. But jump forward 10 years, and this paper was published in 2016, and you can see that this is effectively a heat map across the globe. The darker the colour, the higher the number of clinics. As you might be able to notice, in America, there is actually the largest stem cell industry. Now, just to be clear, these are stem cell treatments, usually cells derived from fat following liposuction, and they're the patient's own cells. One of the charms in terms of marketing is, as that previous slide showed, because they're from the patient, the treatments are marketed as being 100% safe and almost natural because they're from you. This paper went on to look at the different types of treatments that the stem cell clinics were claiming that they were able to treat. And this is quite a busy slide, but the red arrows highlight various either orthopedic or arthritic conditions or pain. In this lower example, I can see, I forgot to highlight this one here, but you can see that they're obviously targeting musculoskeletal issues. And as we know, there's a lot of patients out there who are looking for something to alleviate their pain and to bring back the quality of life that they feel as though they've lost. The paper went on further to look at and report, again back in 2016, the number of clinics across the globe. And there's been subsequent papers that show that these figures are actually much higher, at least double in the US, for example. But you can see that Australia is around number 5 on the leaderboard, with 19 clinics selling unproven stem cell treatments. Just to be clear, these are treatments that are being offered and sold outside clinical trials. In fact, there hasn't even been a clinical trial to evaluate these treatments in most of the examples. We did some work, and we've been monitoring this area in Australia for over 7 years. And in 2014, we published a paper where we looked at the Australian marketplace, if you like, and we saw that there were 43 practitioners in 14 clinics. They were all using autologous cells, or that is the patient's own cells, either derived from lipoaspirate or from blood or bone marrow. The pie chart clearly shows the majority of these clinics were targeting musculoskeletal conditions. There were other conditions treated, such as Parkinson's disease, dementia, and autism in one example. But the bulk was musculoskeletal. Last year, we did another study. We actually compared what was happening in Australia with what was happening in Japan. And I'll just highlight the Australian data highlighted in the, shown in the pink, that we identified 70 clinics. Of those, 50 of them were offering treatments for medical conditions. 20 were looking at cosmetic applications. 20 or so looking at cosmetic applications. But as you can see here, again highlighted by the red arrows, most of the applications, most of the clinics that were offering treatment were doing so for musculoskeletal issues or for pain. Again, these clinics were, with one exception, not involved in ANZ CTR listed trials. So it's a big market and it's growing. How is this happening in Australia, you may well ask? And it's a question that we asked the Therapeutic Goods Administration back in 2016. And it's a question that we asked the Therapeutic Goods Administration back in 2016 when we first became aware of this issue. And we were quickly told about an exclusion. So this is a simplified schematic that was drawn up to introduce a new regulation in 2011. And as you can see here, if you look at the middle channel, I'm just going to go to my pointer. If you look at the middle channel here, it was intended in 2011 that human stem cells and cells derived from them would be regulated as biologicals. However, when this new biologicals framework was introduced, there was an exclusion and a series of exclusions, and they're highlighted here on the far left-hand side of this schematic. And the examples were really back to some of the comments Mark raised earlier around either medical innovation or innovative practices that have converted or converged into accepted practices and were self-regulated by that sector. So for example, assisted reproductive technologies was already highly regulated, as was the use of bone marrow and cord blood. However, it's this latter and last dot point I want to draw your attention to. Indeed, when this exclusion, when this guideline was introduced, I just saw I had some animation, sorry about that. There was a very broad exclusion around all autologous cell therapies, no matter how the cells were prepared or used. This meant that any registered Australian medical practitioner could obtain the cells from that patient and give it back to the same patient with no oversight by the TGA, in fact, no oversight by anybody. There was no requirement to conduct clinical trials, and we were very concerned because we felt as though it ignored the potential risk of physical harm, but also put these patients at risk of financial and of psychological harm. We felt as though this exclusion enabled the sector. It provided the practitioners with a sense of legitimacy. And it also made it extremely difficult for patients to navigate advertised claims and to work out what was legitimate and what's not. So we've been calling, along with many other groups, including the Australasian College of Sports and Exercise Physicians, to address this regulatory ambiguity. And over the last 4 years, we've had a series of public consultations, which I'm delighted to say have now culminated in an announcement late last year that the Therapeutic Goods Administration will now address this regulatory ambiguity and make some changes. I just want to quickly go through the changes because I think it's very important that you're aware of not only what's going to be implemented, but perhaps some of the challenges involved. So the first thing is that there will be a prohibition of direct advertising to consumer. The website example I showed you a moment ago should no longer be an acceptable practice. And as professionals in the community, we will be able to write to the TGA and ask them to investigate any concerning practices. When the cells that are used, the autologous cells or tissue that is being used, is being done so in an accredited hospital by a medical practitioner or dental practitioner, they'll be excluded from practice, excluded from the TGA regulation. Now, I'll come back to this point because whilst in principle I think it's very sound, I'm a little bit concerned about the implementation. As we had hoped, the latter two points I wanted to raise clearly respects and acknowledges that the risk level to the patient, and where the cells have minimal risk, that is, if the cells haven't been manipulated greatly, or that the intended use is consistent with how the cell behaves in the tissue from which it's obtained, that is homologous use, then TGA will have minimal oversight. However, if the cell is expanded, as Mark has described to you, you would think is an essential aspect of developing these interventions, then the TGA will have oversight. We think this is a really important step because, of course, any cell culture does change the cell properties and could increase the risk level to the patient. So we really welcome these changes. Just hopping back to point 2, which is accredited hospital, we're yet to have clarity around what the definition of an accredited hospital will be. Does this mean a teaching hospital who, as you would imagine, would have a full governance structure in place to oversee clinical research? Or does it include a day theatre that takes out some kind of minor accreditation? These are some of the things that we'd like to see addressed, and we're in discussion with TGA at the moment. If anyone wants to follow the developments as the TGA roll out this announcement, if you just search for regulation of autologous cells and tissue products, you'll be able to see a timeline that TGA are developing. So stay tuned. I think it's a really welcome change for the Australian sector, and hopefully will actually incentivise clinical trials, because as you can imagine, at the moment, there's very little incentive to conduct a clinical trial when you can do so and charge a vast sum to experiment on people. I should make it clear that most of the clinics that are currently in practice are charging around $10,000 per intervention. They're also freezing cells. It's often unclear exactly what they're freezing, but they freeze the cells and they can administer the thawed cells at a later date. So in terms of a business model, it's been quite successful for them. In addition to asking for the TGA to have greater regulatory oversight, we've also long recognised that professional standards need to be articulated and in place. And in fact, it's been my great privilege to work very closely with the International Society for Stem Cell Research for over a decade now, where we've really grappled with what are the standards, what are the benchmarks, if you like, to take promising stem cell-based discoveries from the bench to the clinic. If anyone's interested, you can download our most recent set of guidelines that were published in 2016, and this sets out, I think, a very detailed framework in which to see the progression of this field. I'd also like to acknowledge the contribution by the International Society for Cellular Therapy and their efforts to also address any ambiguity and ask for standards to be in place. Finally, I want to acknowledge the college. As you know, the college is co-sponsoring tonight, and Mark's now going to talk a little bit more about what the college has done to address this issue. But as a concerned scientist, I was so delighted when I heard that the college was taking this stance, because I felt as though it brings into question professional ethics, and that should be at the core of all practice. So, Mark, back to you.
Thanks, Megan. Well, we as sports physicians were targeted by some of the biotechnology companies in the country. We do have patients who are high-profile athletes, who are wealthy, or who are desperate to try these therapies. So that was used a bit. That could be used in marketing. We also have doctors very skilled in injections, and because we're non-operative practitioners. So a number of our sponsored by some of these stem cell companies in the country. My particular experience was when a rep came to my door and said, the second words that were being said was, "Would you like to earn $10,000 for doing a procedure?" Well, that sounds very good money for doing a liposuction and an injection. And sure, there is significant cost in setting up the clinic and setting up the and paying for the support of the company, but it still could have been very attractive. Anyway, when you actually looked at the evidence, it wasn't really there. So the College of Sports Physicians has devised a clinical position stand in late 2015. Now, we wanted to support clinical innovation. One of my, I guess, criticisms of some of the stem cell research groups is that they didn't want to support clinical innovation. That's what it appears. But clinical innovation is a really important driver of medical process. So we supported innovation, but once you've got a bit of innovation looking that this therapy may or may not be effective, we really wanted to go the next step and encourage our members to adopt clinical trials. Admittedly, it was very difficult to do. That approach has been, we reviewed all the evidence very carefully, and at the end of the day, it was felt that there was insufficient evidence for promoting or administering this treatment at present. The college supports clinical innovation up to a point when positive results may indicate a research approach should be adopted. In August 2016, there were some adverse reports of particularly a death in Sydney, where the coroner quoted this treatment as quack medicine and was very critical of the medical profession. And some other side effects, there were some deaths as well from the biopsy, not from the actual stem cell. It's from the liposuction or the bone marrow aspirate getting infected or bleeding. But as a result, the College of Sports Physicians changed its policy, saying we can't even use it, we shouldn't be using it as an innovative therapy. There were further minor amendments recently. But at the end of the day, this position stand has been a bit controversial for some of our members, but at the end of but ultimately it's been very well received internationally and it's been published in several journals. So, in summarising my part of the talk, I think there's insufficient evidence to show that high-dose expanded mesenchymal stem cells are efficacious in musculoskeletal conditions. And that's the high-dose ones, the research-grade ones. So there's no current evidence to support the use of non-expanded autologous mesenchymal stem cells. The dose is far too low, even if it is proved to be efficacious at some stage in the future. And they're almost certainly working by a placebo effect because they're subtherapeutic. It is fair to say that some practitioners have developed business models using autologous mesenchymal stem cell therapy using the medical privilege of providing an innovative therapy without undertaking rigorous clinical trials. If they did try and suggest this was a clinical trial, most human research ethics committees would not pass it because charging $10,000 to a patient for a clinical trial is not acceptable. It is unethical. Medical practitioners are definitely receiving significant financial gain by using, or shall I say, misusing an innovative therapy. There's a potential financial conflict of interest. And I think it's a little disappointing that that little action has been taken by professional bodies, and there's been very few clinical guidelines. Besides ours, the Australian Rheumatology Association and the AOA have a small position stand, but there's no clinical position stand guidelines. And what Megan just said is the TGA have pointed out that we're not allowed to advertise it. Well, I thought that was what clinical practitioners had to not advertise anyway, and that's what boards like APRA should be looking at anyway. So I'd like to go back to Megan, who will just finish off.
Thanks, Mark. So I just wanted to help you navigate through trying to see the college's position statement. Go to their website and you click on resources. Under resources is a position statement tab. And then, of course, at the top there, you can see their new statement. It has a great list of references to back up some of their positions. So I'd encourage you to join. The final thing I wanted to mention is I think it's really important to get the facts out there on stem cells. I'm part of a large Australian Research Council funded initiative, and this is one of our core objectives. But I think we're deluding ourselves if we can think we can do this in isolation. I think the only way of getting our message out in the community and to, I think, combat some of those headlines, those sensational headlines we saw earlier, is to work with groups like MOVE. So these are kind of the questions I often get, and I get hundreds of inquiries from patients every year. Again, this lady is very typical of what Mark described earlier. She has osteoarthritis, can no longer garden. She's looking for someone who is successfully doing this, and a specialist. That's a great set of questions to ask. And what we've been doing with MOVE is to work on some resources. So we've developed a short fact sheet with a few other hyperlinks at the back to further reading. But we've also been working with MOVE and the college to convert their position statement into 5 things that we think you should know about stem cells. And again, for additional reading, people can read the full statement. But we think this is very helpful, and I hope you could use it in your practice. I finally just want to say that what we are trying to do is obviously accelerate discovery. We want to see stem cell medicines in the clinic. But we also want to make sure that consumers are well aware. And these are some of the warning symbols that I think beautifully encapsulate our concerns. We often try to raise that if it's not part of a clinical trial, think twice. If the same treatment is being offered for many conditions, think twice. If they're asking for payment, think twice. If the benefit is based on patient testimonials or there's claim of no harm, again, think twice. And ultimately, there is no such thing as a stem cell specialist. A hematologist is about as close as it gets. We encourage people to go back and speak to their doctors. And I think for you out there in your practice, if you could just be bold and have this conversation with people, I feel like many, like the lady who I just showed you who wrote to me, many people are searching for a more balanced conversation about whether this is a realistic option for them. But sometimes they don't quite know where to turn. And as I hope I've illustrated, unfortunately, the internet is very, very happy to fill that gap. So I'm going to stop now and throw back to Jen for questions.
Thanks very much, Megan and Mark, for what I think is just an incredibly important topic this evening, and to cover all the elements that you have has been really very comprehensive. I urge anyone who might have a question to type it into the chat box now. There was a question earlier about whether the recording of tonight's webinar is available, and everyone who registered for this evening's webinar will be receiving the recording, and we can also double check about the PowerPoint presentation. There was a query with regards to whether you might be aware of any lawsuits that have been taken out in relation to patients who have been inappropriately treated with stem cells and so on. Mark or Megan, would either of you have a response to that query?
So Mark, can I just jump in? You may know something else, but I'm just going to jump in and say that I'm not aware of any lawsuits in Australia. However, some colleagues overseas have just recently published a paper in Nature Regenerative Medicine exactly on this topic, and I'm very happy to provide a link to that. I also want to say that this is a really, really difficult way to regulate the sector. In fact, even the complaint system at the moment, through APRA, through ACCC, and ultimately, hopefully through TGA when the new laws are introduced, it's a very hard ask for these people who are in pain, who perhaps are searching for something to help them, to be committed enough to follow this process through. I have several examples of people who are dissatisfied, perhaps not agreed, perhaps not, and we come back to the death of Sheila Drysdale, but they feel as though they've been hoodwinked and are not satisfied with the outcome, but are not also prepared to go through the lengthy process. So I'll stop there, and Mark, I don't know if you want to say something.
Thanks, Megan. I'm not aware of any specific lawsuits. It is very difficult to launch a lawsuit against a company or an individual. What I do know in my clinical experience is I've probably seen about half a dozen patients who have had this therapy and it hasn't worked. And they all went in, I believe, with their eyes open. They feel a bit sheepish about it. They all have said to me, well, it didn't work, but I knew I'm desperate. You know, I knew it was going to cost $10,000. The doctor told me it wasn't guaranteed to work, but in his or her experience, he'd had good results. And it hadn't worked for these patients, so the ones that I'm referring to. But I don't think they didn't have any side effects. One patient has lost a fair amount of adipose tissue on her buttocks, and that is a bit of a problem for her. But apart from that side effect, there aren't many side effects from this treatment. Because a liposuction or a bone marrow biopsy done properly is painful, and an injection into a joint is relatively easy and can be done under ultrasound. So the side effect, and I believe that treatment are fairly safe, but if they're of no benefit, the only outcome is going to be patient cost and potential infection or bleeding. There are a few cases. There's been the one case in Sydney where the coroner took a doctor to court in a published case, the Sheila Drysdale case, where a patient died. Surprisingly for me, that patient was receiving intravenous fat into her veins for dementia. Now, injecting, those of you in the audience who are medical would know you can't inject a substance into a vein and expect it to get into the brain if it's a cellular product because of the blood-brain barrier. But anyway, unfortunately that lady died, and that was the case that was referred to as quack medicine. She died from complications of bleeding. Do you want to comment on that, Megan?
Yeah, I was just going to say that if anyone's interested and wants to download a podcast, Anne Arnold from Radio National Background Briefing did an incredible story on the stem cell industry and also wrote some blogs about this case. And I think the point that I wanted to mention was, at least from the husband's perspective, and he actually sought out the treatment for his wife because she was unable to give consent, her dementia was so advanced. He holds no ill will towards the doctor in question. So I think, again, it's an incredible story to perhaps remind us of this challenge and I suppose great responsibility that medical practitioners have in terms of enabling or perhaps thinking twice about these interventions.
We have another question here in relation to, are either of you aware about any sort of clinical trials currently happening, and is there any chance that there's sort of good quality evidence just around the corner? Good quality evidence just around the corner.
Megan may be able to comment a bit more on this, but I believe there are good quality clinical trials there are registered trials that have yet to be published on using expanded mesenchymal stem cells in conditions such as tendinopathy and articular cartilage regeneration in osteoarthritis, but they have yet to be published. So I think there are some being undertaken. There are lots of clinical trials which are of poor quality due to they're not proper clinical trials. I've treated 20 patients and they all told me they had got better type of thing. There's lots of those clinical trials. They're not good quality trials, but there are a few being undertaken. Megan?
Yeah, so thanks, Mark. I just wanted to mention, following on from that comment, there are case series being conducted. They are actually listed on the ANZ CTR, and again, this is a pay to participate. So I think some of the issues Mark raised need to be taken into consideration when we review the evidence from that. I do hope, though, we do start seeing some higher quality evidence, and it may be for many reasons that the evidence comes out of allogeneic MSCs. Being able to monitor for batch variability on an individual sample for a patient it has enormous challenges. So perhaps the evidence may well be from an allogeneic source, from a donor. And I think we just have to wait and see. The final point I want to raise around that is that let's not extrapolate. If a study shows benefit for a particular application, such as an intra-articular injection that causes cartilage repair, let's just not extrapolate to perhaps other conditions. And I think outside musculoskeletal conditions, there are some very early stage but promising work around using stem cells as a source for replacement cells for things like particular eye diseases or for diabetes. But again, the jury it's far too early, the jury's out.
And Megan, that was very good advice to direct people to the Stem Cells Australia website and also our Move Muscle, Bone and Joint Health website to look for patient information and also information for health professionals. So if health professionals want to stay in touch with this issue, would you suggest that they stay in touch with the Stem Cells Australia website and also the college's website? Are they the two best sources to get an update on what's happening in this space?
That and some of the international sources that we hyperlink to in our fact sheets. One other thing that we might want to be aware of is that the National Health and Medical Research Council did publish a quick guide for GPs. And again, perhaps we need to make that more available, Jen. But I think that's an excellent resource as well.
Right, we're right on 8 o'clock, so we might finish up there. And I think it's most interesting to watch the developments with the TGA, given those changes to the sort of regulatory environment towards the end of last year. So that will certainly be an interesting space to watch. Can I thank you very sincerely, Megan and Mark, for a very interesting and important presentation this evening. I'll ask all participants to complete the feedback questionnaire, which is on your screens now. And on that note, I'd like to thank you all for joining us this evening and remind you about our other webinars coming up. There's one on the 27th of March, which is about axial spondyloarthritis. So I'll direct you to our website to gain information about that webinar as well. So on that night, can I bid you all a very pleasant evening and good night.